Adam, thank you, and thank you everyone for giving me the honor to come and speak at your grand rounds. It's obviously just a great honor to be able to present at such a well-respected and historical place of urology. So thank you so much. And this is a topic that is pretty near and dear to my heart. I've been giving a variation of this talk for close to over a decade. I would say over a decade now. Um, and the most recent iteration, the one that y'all are going to see, um, is really kind of a PowerPoint presentation of a paper that will be published in the Gold Journal. I think it's going to be this month. It's already been e-published. So a lot of the stuff, if you run across that article, you'll see a lot of this stuff here. It's mine, so that's the reason why I'm using it. But anyway, sort of get it out of the way. I have no disclosures. And so what I'm going to talk, today is going to be a review of the literature. And I apologize in advance because I know that can be um, sort of dreary if it's done in the wrong way. But I really do think going back through the history and then looking at what the more recent data shows is pretty illustrative of how we've come to this moment in time of pediatric urology management. So I'm gonna touch relatively briefly, but try to give a little bit of detail and color on the what's considered the sort of the bellwether um, papers in the development of the idea of vesicoureteral reflux as a pathologic condition. But then I'm going to spend probably the majority of the time going over the 9 randomized controlled trials that have been published since 2006 on this topic. And I am doing that because I think it really presents, to my mind, in the way hopefully I'm able to convince some folks today too. Um, when the data is presented all together, there's a very, I think, compelling argument for what I'm going to propose in terms of management of vesicoureteral reflux. And due to that, this is not going to be didactic in the sense of like going over the pathophysiology and stuff like that. There will be some assumptions uh, uh, on that the crowd knows what VUR is on a very basic level. So just a couple of quick acronyms because I will be using these: VUR, vesicoureteral reflux, and CAP is continuous antibiotic prophylaxis or just prophylaxis. So really briefly, what is reflux? It's urine going back up into the kidney from the bladder. It's been considered for decades to be a risk factor for kidney damage, is the short story. There are 5 grades. Generally, pediatric urologists group these into non-dilating and dilating. Non-dilating is grades 1 and 2, and dilating is grades 3 and up. And honestly, a lot of folks sort of treat grade 5 as its own special category as well. But the broad differentiation is between dilating and non-dilating. And so I remember learning about VUR when I was a resident. I couldn't quite get my mind around what it was we were supposed to be worrying about. And so I always, whenever I'm talking to anyone who isn't a pediatric urologist, I always try to focus on what is it we're actually trying to prevent. And it's renal scarring. That's really the main goal for treatment of vesicoureteral reflux. Now, I think there are ways to couch that it's not just renal scarring, but the main thing is we're trying to prevent the type of kidney damage that's going to lead to poor renal outcomes in the future, such as hypertension, proteinuria, and even end-stage renal disease. And I put an asterisk on the renal scarring because I could give a whole topic on a whole talk and actually have on how our ways of knowing what renal scarring means are deeply flawed. But all that being said, we're going to assume that we know what we're talking about when we're talking about renal scarring. in this patient group when we're discussing this these articles. I'm sorry, I tend to bloviate, so I'm giving myself a timer here, and I need to set that. Okay. Um, so like I said, I was going to do a little bit of a history lesson. The first, like what's considered and I say it's considered this because it's been propagated through Campbell's for like 40 years that really the initial paper that started talking about vesicoureteral reflux as a potential pathologic condition was done by Hutch in the early 50s. Hutch was a pathologist that worked in the VA system in Virginia, and he worked with returning veterans from World War II who had been paralyzed. And he found that a lot of these patients were dying from end-stage renal disease. And he was one of the first to publish that a paper reporting what he considered to be the natural outcomes of vesicoureteral reflux and untreated vesicoureteral reflux. But this is where, and I would actually encourage any resident that's listening to this talk is like, if there is a management scenario in urology that doesn't make sense, go back and read the original papers because what gets transmitted and what's actually written is a lot of times, in my experience, two different things. And what I mean in this situation is that there's a lot of expert opinion in these papers, and that's where we were. That's not an accusation at all. I know folks were trying to do the best they can, and we didn't have the regimented way of looking at things that we do now, 70 years ago. But there are several comments in this paper that just are sort of assuming that everyone already knows that reflux is a problem. And then when you go and try to chase these references down, these papers all refer each other. They don't really refer to any experimental evidence. They just talk about expert opinion for the most part. The next paper that is considered, again, one of the hallmarks is the Hodson and Edwards paper, and that was out of 1960. And this is essentially the one that put together the radiologic piece of vesicoureteral reflux in terms of being able to see that reflux plus an infection causes pyelonephritis, causes a change on a radiologic exam. And again, this was a retrospective paper. It was a small paper, and it was actually both adult and pediatric patients. So they were receiving patients whose past medical history they didn't really know, or they sort of knew very vaguely. So again, this is a situation where you have patients like in the Hutch paper, where in the modern era in the Hutch paper, they would, because these were all patients with neurogenic bladder, the kidney damage would be considered secondary to the neurogenic bladder. It wouldn't be necessarily due to the reflux. And in the Hodson paper, a lot of these patients, they didn't know what the history of these patients were. So they were just getting a snapshot of what had happened to these patients. There were several other papers that were published regarding this, but really the next one that started moving the needle, and this is really one of the landmark papers in the whole VUR renal scarring sort of pathology paradigm, is the Norman and Smelly paper in 1965. And Dr. Smelly is anyone who manages VUR knows, is a giant in this field. She's I don't know if she's still living, but she's a British nephrologist, if I understand correctly. And this was a paper where they looked at patients who had had a bunch of recurrent UTIs in the prior year. There was a unit in the hospital that they were working in that dealt specifically with these patients, and then they started these patients on 6 months of a variant of trimethoprim, I believe. And then they looked at how many episodes of UTI they had in the treatment phase versus the prior phase versus the pretreatment phase, and they found that there was a decrease in UTI recurrence from 2.4 in the year prior to below or zero point 0.24, I believe, in the treatment during the treatment time period. And this was something that really galvanized thought on how you can actually approach these types of patients who are getting recurrent UTIs. But again, something to keep in mind is it hasn't really completely coalesced in terms of VUR reflux, or excuse me, VUR UTI renal scarring and what we should be doing in terms of the treatment paradigm. They did not assess VUR status in these patients. They were just treating patients who had had UTIs in the past. And one of the problems with this paper was that the incidence of UTI prior to the treatment was largely self-reported. So they were just basing it on patient recall. Another paper by O'Donnell and their group was in 1969. And this, again, was not a randomized group of patients. It was just a consecutive group of patients. And they basically split them up into who didn't get any treatment at all, who got continuous antibiotic prophylaxis, and then who got surgery and prophylaxis. And this was the first paper to really at least demonstrate in a retrospective setting that continuous antibiotic prophylaxis, or even just treatment in general, could have some effect on renal scarring. And then actually Norman and Smelly published another paper. This is the Edwards paper. And they were one of the first to show that actually VUR resolves. So at least some of it does. And so all the pediatric urologists who are listening to this talking kind of start to see the glimmer of the paradigm that would come to dominate the management of this condition, really up to the present day to a certain extent. But I'll touch on that in just a second. But I would also like to point out that this entire time, no one has really figured out which way the causative arrow points, meaning that there's been some associations, but the idea that you've got reflux in an unscarred kidney that then creates new scar on a pathologic level had actually never been done before. No one had run that laboratory study. And then Ransley and Risen, again, these are British nephrologists, did a very interesting study where they took a series of pigs and they induced reflux surgically on one side and then used the other side that didn't have surgically induced reflux as their own control. And then in some of these pigs, they put in a wax ball that was impregnated with the porcine version of E. coli. They put it into the bladder, and then they tied off the urethra, and then didn't treat it for 4 weeks. And in some of these pigs, they didn't tie off the urethra, but the tying off the urethra was like high pressure reflux versus low pressure reflux. And what they found is in the pigs who had the porcine E. coli introduced, after 4 weeks of non-treatment, they were pathologically, they would sacrifice the pigs and they were finding renal scar on pathologic exam. So as any, this is not very close to what happens in sort of clinical scenarios, obviously. It's not surgically induced reflux. It's not untreated for 4 weeks, and it's not introduced via foreign body. But still, at least this shows some actual evidence of a causative relationship between reflux leading to a change in the kidney that has been documented pathologically. But even these guys pointed out, and actually this is probably where the whole idea of the Big Bang Theory, where most kids with damage due to reflux are born with it, is that they make this comment that The major problem is the rarity with which a pyelonephritic scar is found in humans in a previously unscarred kidney. And the corollary to that is that most scarring happens before birth. That's actually in their paper. So again, it's sort of pointing out that okay, we've established this, but we're not really sure what we can do about it. But with all that, there was, and again, for some of the folks who maybe have lived through this, I know Dr. Weiss is on this call, and I am very nervous that I get all this stuff right because this is his paper I'm about to talk about. But the emerging paradigm again based on what I've seen in my study of this time period is okay. Now we've got a condition that does appear to be a threat to the kidneys. It does potentially disappear with time. Kids can age out of it, and we've at least got some evidence that prophylaxis can keep kids safe while they're aging out of this. But there hasn't been a coalescence of how we should be treating patients with this. And these studies, there were three that were really important in terms of solidifying this paradigm of treatment with CAP, allowing the child to grow out of the VUR, and then surgery for breakthrough infections. And the granddaddy of all these is the International Reflux Study. As I said, Dr. Weiss was the lead author on this. And this was actually a study done both in Europe and in the United States, and essentially took kids with dilating reflux. So grades 3 or high, grades 3 and 4. I think grades 5 were excluded, and they were randomized to either CAP or surgery, and then followed. Birmingham reflux study was a very similarly designed study. The kids were a little bit older. They went up to 15 years of age in that group, and they had lower grades of reflux. They were mostly grade 3 with some grade 2, although the grade 2 typically had renal scarring associated with it. And what they found was there was no difference in terms between surgery and CAP with respect to renal scarring. Again, going back to my original points, like that's what we're trying to prevent is renal scarring. Now, surgery was found to reduce pyelonephritic episodes, but because the whole point was to prevent renal scarring, this was what gave credence to the idea that we can potentially allow kids to grow out of this, that we can uh, it's a safe regimen to keep them on CAP, repeat the VCUG in a year or 2 years or however long, based on how old they are, and then do a reimplant if they have breakthrough infections. And that was really the paradigm for essentially the next 15 years, because the Southwest Pediatric Nephrology group paper was published in 92. And this is the one that really solidified the idea that VUR can resolve, but the higher grades resolve less frequently. So especially the dilating reflux resolves less frequently. So now we've got these papers and we've got this paradigm. I know I sound like a broken record, but there's a point to it. It's like we're going to we have a condition that will resolve with time. We're going to keep the kids safe with CAP, and then if they have a breakthrough infection, then we intervene with a reimplant. But there was in all these actually extremely well-designed studies, and studies that still have a lot of meaning and up to this day and age, there was a significant factor missing, and it was a placebo. No child was simply just treated as the UTIs arise. And again, it was because of all this prior evidence that was indicating that at least people were reading it as reflux with infections was a significant risk to the kidney. So it would be malpractice to not perform placebo. But starting in the new century, this thinking started to change a little bit, and it was probably the first shot across the bow, I guess, was by Craig, who is an Australian urologist, I believe, who looked back at the kidney transplant rates in Australia in the era of active vesicoureteral reflux intervention. And what he found was that there was no change in the ESRD rates due to reflux nephropathy over that time period. It hadn't budged at all. Um, and so he asked the question uh, or raised the possibility that reflux is a pathologic condition, but all of the changes and all the pathology may be baked in by the time we see the patient or see the child, and our interventions aren't really doing much. So interestingly enough, it wasn't really pediatric urologists who led the charge in terms of figuring out whether or not our interventions are really doing anything other than above just sort of treating UTIs as they arise. But then in 2006, there was it started a rush of randomized controlled trials. And this is the beginning of the talk that I was speaking about in terms of I'm going to be talking about 9 randomized controlled trials. And I've got the first 6 listed here. I'm doing it in a particular grouped order, which hopefully will become clear why I'm doing that here in a minute. But it started with Guerin et al., and that was a multi-center study that was based in Florida, Spain, and I believe Venezuela. But in rapid succession, 6 different randomized controlled trials were published on vesicoureteral reflux with a placebo/no treatment arm involved. So before I get into those, and again, I apologize. I know there are probably some people in the audience be like, he's not really going to go through each one of these studies one by one. I will, but I'm going to sum it up, and I'm hoping that it's compelling enough that it's worth sort of going through it with me here. But as we're going through these studies, I think it's important to really consider what are the questions that are being asked, what are the questions we need to ask. And so several of these papers actually asked, does VUR have any relationship to increased chance of recurrent UTI? There was actually just 2 papers that asked that question. And believe it or not, I'm not even really going to focus on that too much. But or actually 3 papers because the River study did as well, although that wasn't a primary or secondary endpoint. Because I think the other things that we're going to talk about are compelling enough to make the point I'm going to try to make. And then another question is, does any of our interventions decrease the chance of recurrent UTI? And remember, CAP in these settings, in these studies, which is what the active treatment is in the vast majority, in all but one, really, is a stand-in for treatment in general. And the thought process behind that is that CAP was found to be equal in those 2 prior studies, to surgery, the Birmingham reflux study and the international reflux study. So that's a stand-in for all treatment for vesicoureteral reflux. Does intervention reduce chances of recurrent febrile UTI? And that's an important distinction because febrile UTI is considered to be pyelonephritis in kids. Symptomatic UTI without a fever, not necessarily an infection of the kidneys, although a lot of times it gets grouped in in these studies. But it's actually, at least if you believe the paradigm, it's a distinct entity to just UTIs in general. Does intervention decrease chance of renal scarring? And again, that's supposedly the whole point of why we're doing all this. And then finally, does intervention decrease hospital visits? So I'm going to sum up the findings for all these studies, but I'm going to talk about each one in a little bit of detail just so you understand that we've actually covered a lot of the potential subgroups that could be affected by vesicoureteral reflux. So as I said, Guerin et al., this was the first study. They actually had a pretty broad range of patients that were being followed. all the way up to 18 months excuse me, 18 years of age. These were lower grades of reflux. They had grade 3, but most of it was grades 1 and 2, so non-dilating. They were randomized to CAP or no treatment for 12 months, and then the endpoints were types of UTI, so symptomatic versus febrile, the rates, and then incidence of new renal scarring. Panisi et al. This is an Italian group. These were younger patients, ones that we theoretically should be more concerned about in terms of the impact that this condition can have on their kidneys, with a first febrile UTI, and actually somewhat higher grades of reflux. They had grade 4 in this study. And again, it was actually CAP versus no treatment, but this was a longer study. They followed them for 4 years, and they looked at recurrent febrile UTI rates and renal scarring rates. Roussy-Kessler is a French group, and this was a little bit unique because this is the only study that did not look at renal scarring. These are younger patients, lower grades of reflux, and they were followed for 18 months. Again, CAP versus no treatment, and that's essentially the treatment algorithm in all of these, or the treatment breakdown in all of these studies. Again, febrile overall UTI recurrence rate. Montini, again, this is an older age set up to 7, and just for folks again who don't handle VUR, we're not as aggressive in looking for VUR in older kids, and the thought process is that older kidneys are more resilient to infections. It also happens that kids don't get fevers as often with UTIs when they're older versus when they're younger. Again, randomized to CAP versus none. This is a shorter study, 1 year, and also looking at febrile UTI and new renal scarring. The last two are Craig. This is the same one who published the paper in 2000, noting that there was no change in end-stage renal disease rates. And this study went all the way up to 18 years of age, and I believe this is actually the biggest study out of all of these. They had over 500 patients in this study, and it was just symptomatic UTI. They did a subgroup analysis for kids who had VUR versus none. And this was countrywide. This was across Australia in the way they did this, and it was CAP. And they actually had a placebo arm. The other ones didn't have placebo. It was just they didn't get treatment. But with the CAP, they actually had a placebo. And again, same endpoints, new and febrile UTIs and renal scarring. They actually also looked at hospital utilization as well, and a couple others that I will talk about did as well, and I'll talk about what that means in a minute. And then Brandström was actually the Swedish reflux study. This was interesting because they actually had 3 separate treatment arms. They had CAP, they had surveillance, and then they had endoscopic therapy, so essentially a form of deflux to treat these patients. They were followed for 2 years, and the primary endpoints, febrile UTI, new renal scarring, although they published 5 different results papers on the different analyses that they did. It was, they generated a lot of data out of this study. So what did all these show? So it was, hopefully this summarizes it pretty well. I've broken it down based on those questions that I highlighted at the beginning before I got into the talking about the randomized controlled trial. So if you look here on the left, does intervention decrease all UTI recurrence? So these are the papers that were looking at all UTIs, so symptomatic and febrile. All right, so 2 said yes and 1 said no, and so that's out of a total of 6. So that's whether or not they found a statistically significant difference. And I want to be clear, that can be different than what could be a clinically significant difference, and if the study was powered to find that difference. But as you can see in another column, I actually highlight that. what those differences are. And then more importantly, if you believe the paradigm, the pyelonephritis leads to renal scarring, does intervention reduce pyelonephritic episodes? And actually, four of them said no, and two of them said yes. Now, some of the controversy here was that the ones that said no had lower grades of reflux in some of them, but there was actually a pretty broad range of reflux in the ones that found no difference and it didn't seem to be really that much different than the ones that did find a difference in terms of reduction of pyelonephritic episodes. But more importantly, I want to point out that there was actually no statistical decrease. Like when you compared the two arms, the percentages were not decreased in four of them. And the other two, the Craig paper, the difference was actually quite small in terms of the pyelonephritic episodes. And Brandstrom, their findings were sort of outliers in a lot of different ways, but they found a huge difference between treatment and non-treatment arms, close to 40%. But then when you look at renal damage, as I said, Rusi Kessler were the only ones that didn't ask the question, does it change the renal damage? And none of them found a difference. Now, Brandstrom made the comment as like it potentially our study was not powered to detect this difference. But I would point out that as you look in the last column, the difference in renal damage in all the other papers was minuscule or actually favored non-treatment. So again, Brandstrom is a little bit of an outlier here, but it actually drives what is essentially kind of a step function in terms of randomized controlled trials in VUR, and that's actually the River study, which I'll talk about in a second. But so the Brandstrom was published in 2010, and then in 2011, the AAP changes their recommendations on screening for VUR. And so they said, children 2 to 24 months of age with a normal renal ultrasound, it is not advisable, is not recommended to look for vesicoureteral reflux in these children with a first febrile UTI. And interestingly, people really paid attention to this, despite there still being a lot of pushback in the pediatric urology community about these findings. And I remember I was actually finishing fellowship when all these things were coming out. But a paper published in 2018 went and looked back at I think it was Medicare data for the use of VCUGs, and there was a significant drop. And my guess is this was actually driven by pediatricians. I do think pediatric urologists started changing their practice. Again, I remember these conversations, but a lot of it, I think these kids just weren't coming to the pediatric urologist because this AAP recommendation gave cover to the pediatricians to not send for an evaluation. But in the background there is a study being developed that is really kind of the one study to rule them all, as you would say, and that's the River study, and that's the randomized intervention on children with vesicoureteral reflux. And the whole idea here was it was really focused, at least all the discussion I remember and reading about was this idea of whether or not our treatments changed UTI rates. Because if you remember in the table I presented, there was not a lot of good evidence to show that the interventions were changing UTI rates. So the River study was designed to really answer that question definitively. And this is honestly, I think this is an incredible study. It was extremely well designed. It was a multi-center study done in the United States. And they looked at kids up to 6 years of age with a first or second symptomatic UTI. So it didn't have to be febrile, but they did have to have reflux. These patients were randomized to CAP versus placebo and followed for 2 years. The endpoints were new symptomatic UTIs, renal scarring, treatment failure, and that's patients who had, I believe, three or more breakthrough UTIs despite treatment. And then antimicrobial resistance. They did do an analysis of hospital utilization as well. And to sort of not bury the lead so much, they found a statistically significant advantage in subjects receiving antibiotic prophylaxis in the prevention of new symptomatic UTIs. And this was a very big deal. It's not common that us pediatric urologists get published in the New England Journal of Medicine. So obviously, this generated a large amount of discussion, and a lot of it was around that. Okay, well, the AAP needs to change their guidelines because now we've definitively proven, because this is the best designed study by far, um, that that we can reduce we can reduce recurrent UTI. Well, the AAP was sort of like, I'm not sure we really agree with that because ultimately, if you look at again this column here, um, where the rubber meets the road is still not changed at all. Now we've got 6 out of 7 studies asking the question, does our intervention change renal damage? And the answer is no. And again, I'm highlighting that what the actual statistical differences were, because that comes into another argument that people have made about this that I want to address in terms of the fact that we're not finding a change in renal scarring. Um, but the AP doesn't change their guidelines. And despite the fact that that everyone thought, at least my memory of this and the discussions I had, and I definitely remember thinking this myself, that the River study was going to settle this. It didn't. I think it moved the needle, and it started making people think much more along the lines of targeted or risk stratification therapy. But there were still questions, and especially from because the AP really wasn't budging on their guidelines. The question was like, what are we supposed to do with these patients? What's the effect we had? Um, there's actually, since the River study, there's been 2 more randomized controlled trials. One out of India um, in 2015 that actually looked at older, again, young, broad range of kids with higher grades of reflux. They were randomized to prophylaxis versus placebo and endpoints of recurrent UTI and renal scarring. And then the final one, and this is the Morello paper is a European paper, and it was a bunch of different academic centers involved. This was a very interesting paper because this focused on the groups of patients that we are worried about the most, and that's little kids, infants, newborns with high grades of reflux, including grade 5. And this is really unusual because, except for the Swedish study that did a kind of a sub analysis on group 5, no one has really looked at what happens to grade 5 on a large scale, I guess. These patients were CAP versus no treatment, and they were followed for two years. And again, the endpoints were recurrent and febrile UTI and renal scarring. So what do they show? Pretty much the same. There was some, the Hari paper actually reported that all outcomes were worse, or excuse me, that there was an increased risk of UTI on patients who were taking prophylaxis, and the difference in renal scarring was non-existent. And as you can see, it was 0.1%. Morello, they did find a decrease in recurrence risk along the same lines as the River study. But again, they did not find a change in renal damage. And this is really what I want to sort of emphasize. So there are now 9 randomized controlled trials that have been published with a no treatment slash placebo arm in VUR. And out of those nine, eight have sought to determine whether or not we have an impact on renal damage slash scarring. And that's the whole point. Again, not the whole point, but the primary point of treatment of VUR, right? Like UTIs by themselves, except in really small kids who can get a bloodstream infection from UTIs pretty easily. Older kids, UTIs in terms of symptoms, it in and of itself, it's most of the time it's really not even any worse than the common cold. Um, but it's the renal damage that we worry about. And as you can see, we're not seeing any difference in our outcomes. And more importantly, and I'll touch on this again, the difference is even if we're not seeing a statistically significant difference based on chi-square or whatever, you can make the argument, well, if there's a huge difference and we're just not picking it up, it's just not powered to see it. But if you look at the differences are either it's actually in favor of no treatment or outside again of the Swedish study, they're tiny. The differences are tiny. So in summary, what do we have based on these nine randomized controlled trials? We have a condition where the treatments, even if you're just looking at the ones that were positive for a statistically significant difference, the treatment sizes are smaller. I'll go back. These are the absolute decreases, right? Now, a lot of times people will say when they're referencing specifically like the River study, they'll say, oh, there was a 50% risk reduction. Well, that's a relative risk reduction because the risk of UTI over 2 years based on the River study, and this actually appears to be, looks pretty consistent across the studies, is about 24%. And then people who were on CAP, it went down to 12%, roughly. So it's the absolute risk decrease that I think is more illustrative of of the effects that we're having. But it's also an indication that you can present things in any form you want, and it can be compelling both ways. But based on my read, based on this data, these appear to be small effect sizes. There are low rates of renal scarring in these patients. I didn't put it on the table, but the vast majority of actually all but one of them, again, it was the Brandstrom study, had anything above 10% new renal scarring over the study period. The Hari paper, I think it was 16%, but then everyone else was 10% or lower. The Craig study was like 5%. The Panisi paper and the Garin paper, those were they were well below 10%. So it's at least, again, if you're looking at the highest quality data that we have, the rates of renal scarring are really low. But really, I think something that isn't talked about enough, and the reason why I give these talks all the time, is that our interventions don't change these rates. They don't change the renal scarring rates. And that's been shown across 8 different randomized controlled trials. Now, the arguments that I have seen and the reasoning I have seen to say, okay, well, we need to incorporate this data and we need to figure out who is at risk and who is not, or honestly, to put it bluntly, why we need to continue to even treat this condition at all. There's several reasons for that I've seen given, and I'm going to try to address all of those. And I'm hoping I'm not getting close to time. I might be, but the first and foremost is it's too dangerous to do nothing. That this is a condition it's too risky to not treat. We've got to do something even if we're not seeing an effect. And the paradigm, and I think that can be a compelling argument. I think a great example of that is pancreatic cancer. If anyone wants to go look at the SEER data over the last 40 to 50 years, we have not made a dent in mortality for pancreatic cancer, but we continue to treat it because if you don't treat it, you're definitely going to die from it. So um, I can understand the logic behind that. Another one, and I already alluded to, is that these studies were not powered to detect a difference in renal scarring. That there's a difference there, we're just not seeing it, and we can't just assume because we're not seeing the difference that everything is fine. It's too risky. Another argument, and actually this is something that I hadn't really been completely aware of until I started going through the editorial process for the paper that this is taken from, is the idea of preventing pyelonephritis episodes that lead to hospitalization. Um, One, I think that most people think about in terms of, okay, uh, we can we'll continue to address this. Um, we'll uh, we'll figure out who it is that's at risk. So it's the risk stratification approach to minimizing the harm that goes along with all these diagnosis and treatment of this condition. And therefore, it's a much more targeted approach, and we're still identifying the patients that are at highest risk. And then one thing, something that comes up, especially obviously in women, are the potentially increased pregnancy-related complications. So I'm going to try to touch on all these in turn. I'm not going to spend a ton of time because I know it looks like I'm probably coming up on time. Um, so the first one is it's too dangerous to do nothing, right? This is too risky a condition. And especially if you're looking back at those old papers, this seems like it seems scary. And especially folks who live through this active treatment era, I think are going to have a different perspective than people like myself who trained in a later era. Although I guess I'm really starting to age into the middle career group here. But as I alluded to, all of these studies did not show very high rates of new renal scar. And I would like to point out that it's renal scar. We're not even talking about actual renal outcomes in terms of hypertension or anything like that. It's just the renal scar rate, and it's actually quite low. Roughly, if you average them all together, it's about 10%. But more importantly to me, because again, I'm thinking about what are the actual renal outcomes. So the IRS study published their 10-year data back in 2006, and this is actually the best data that we have, at least that I'm aware of, with respect to this group of patients. And the patients they had are not everyone, but they're actually some of the higher risk ones. So the kids that were randomized who were included in the IRS study had higher grades of reflux, so dilating reflux, grades 3 and 4 mostly, and they actually had high rates of renal scarring on study entry. So these kids were definitely the ones that we would think are at highest risk for developing some sort of bad renal outcome over time. And it was, again, this is a great study because they were actually able to follow these patients for 10 years. And out of 252 patients that they followed over that 10-year time frame, one patient who had started the study with a normal GFR was on hypertensive medication at the end of it. One. There was one other one who had a subnormal GFR, and they were on hypertensive medication at the end of the study. That is actually lower than the general population incidence of hypertension in kids, which is around 2 to 5%, depending on the demographic. No one over that time frame progressed to a new renal insufficiency. Now, the argument to that may be, well, that's because they were getting treatment. But I was like, but if you believe in sort of logical syllogisms that we can take what our studies, our randomized controlled trials showed, is that we're also saying that there's no difference between treatment and just treating UTIs as they arise. So again, this is not all based on all the prospective data that we have. This condition is not dangerous in the vast majority of kids. Now, Tofolo et al. This is an Italian group, and they also found low rates of renal function decrease for kids who had a first UTI. Okay, so I just looked at the clock. I see I got about 5 minutes less left, so I'm going to try to sum this up. Sorry, I've been talking too long here. Um, but again, I want to address this main issue about these are not powered to detect a difference. And really, I that the I've spoken to statisticians about this and proposed this argument to them and then said, how do you make sense of this argument? And so the only way that I can make sense of this argument, and again, based on conversations I've had with statisticians, is that you're because of these low rates, right? Like 0.8% difference, 1% difference. The outliers 12, but then you've also got three that say that there's fewer scars in the non-treatment group, including one that had high grades of reflux. You're either saying that these tiny differences, and again, these tiny differences that you're ignoring the ones that argue the other way, these tiny differences are clinically significant, which I don't think they are. And it would be interesting to hear anyone make the argument that a 1% difference in renal outcomes is a clinically significant difference. Or you're saying that if you expanded the pool and you had enough patients, this 1% becomes 15% or 20% or whatever you consider to be a clinically significant difference. And then you have to explain, well, why are we now seeing this giant change in the differences when we were seeing such small ones in the prior studies? Pyelonephritis related hospitalization. I'm going to try to cram all this in. The studies that looked at it didn't find any difference in hospital or ED utilization rates. But what they did find was that there were higher rates of resistance to antibiotics in kids who had gotten the CAP. One point about the risk stratification, and Adam and I have had conversations about this already, but risk stratification only risk stratifies who we can reduce UTI risk in. It does not affect renal scarring risk because we haven't found anything that does reduce renal scarring. You can't make chicken salad out of, chicken excrement. So like you can't take something that doesn't show an outcome and somehow make it an outcome by trying to cone down on certain factors. Pregnancy-related complications, and this is the final thing. I've got a bunch of papers here, but essentially all these papers say the same thing. Reflux status actually doesn't matter. It's only if there's been renal damage associated with the kidneys. And actually, there are several papers, and I've got 2 pages of this that show that actually having had reflux surgery was an independent risk factor for pregnancy-related complications. So anyway, coming to the end, in summary, at least to my mind and the way I look at this data, we have a condition that again leads to low rates of renal scarring, and we've got really good evidence to show that. We've got nine randomized controlled trials. We've got long-term data from a prior very large randomized controlled trial, really showing that these renal-related risks are quite low. The intervention that we do have doesn't change these parameters at all. It maybe shifts the UTI rate. It doesn't shift it that largely, but it does not make any difference in terms of the renal scarring. And these interventions come with long-term health risks, specifically the CAP, which I didn't get into, but there's a great paper by Chris Cooper in Iowa called "Fat, Demented, and Stupid" that talks about all of the potential bad outcomes that comes from pediatric urology-based interventions, and he talks a lot about CAP in that. So I just love the title of that. But anyway, in summary, to me, it is, I cannot see a way to justify continuing to screen for VUR in the vast majority of patients. And I would, I know I'm probably going to get some interesting questions from the pediatric urologists in the group, but I think to me the the evidence really all points in one direction, and just to kind of let everyone know where I am, I haven't screened for reflux in a child with an otherwise normal bladder in over a decade. I don't look for the condition anymore in the vast majority of patients.